We're fortunate. Today, we live in a world where every medical procedure, from something as simple as treating a cavity to the most complex surgeries, is performed under anesthesia. But it wasn't always this way. For centuries, surgery was inseparable from pain and suffering. Effective pain relief simply didn't exist. Only in the 19th century did crude methods like alcohol begin to give way to professional anesthetics. In this episode, we'll explore the history of anesthesia. You'll discover what people used as painkillers over 2,000 years ago, the strange and often absurd tricks medieval doctors employed to distract patients from agony, why we owe the invention of the first effective anesthetics to dentists, and how Queen Victoria herself helped popularize anesthesia. But first, make sure to subscribe to our channel and share it with your friends. Now, let's get started. Even in ancient times, doctors understood that healing a patient wasn't enough. It was just as important to ease their pain. The earliest known anesthetic in history was henbane, which the Babylonians used as far back as 2250 BC to relieve toothaches. In the Arab Caliphate and in China, opium was the go-to remedy. In fact, by the 1660s, Chinese physicians had already administered it intravenously for the first time. European scientists ran similar experiments. In 1656, Robert Boyle and Christopher Wren injected opium into a dog's vein using nothing more than a sharpened goose feather in place of a syringe. During the Middle Ages, so-called sleep sponges entered medical practice. Sponges soaked in opium, henbane, mandrake, or hemlock. Doctors would press them against a patient's face, hoping the vapors would enter the nose and lull them to sleep. The first documented case of anesthesia during surgery dates back to China's Three Kingdoms period, around 225 to 265 AD. The famous general Guan Yu reportedly underwent treatment while under the influence of a substance called mafeisan. As the physician Hua Tua removed a poisoned arrow and scraped the infected bone, the general calmly played a game of Go. By comparison, medieval European methods were far less effective. Some doctors rubbed stinging nettles on a patient's hands so that the burning sensation might distract them from the agony of surgery. In medieval Italy, a patient's head was sometimes covered with a wooden bowl and struck repeatedly until they passed out. British sailors facing emergency amputations drowned their pain in rum, a practice that often cost them their lives. Later, at the turn of the 18th and 19th centuries, hypnosis became a popular form of anesthesia. But even in the 19th century, surgery and suffering were inseparable. On one occasion, when the British surgeon Robert Liston was performing a bladder stone removal, his patient, overwhelmed by pain, broke free from the operating table and locked himself in the bathroom. Liston had to break down the door and physically carry the man back to the operating room. But relief was already on the horizon. As early as 1799, the British chemist Humphrey Davy had discovered that nitrous oxide could ease pain. Yet the surgical community ignored his findings. By the mid-19th century, the gas, better known as laughing gas, had become popular at parties in Britain and the United States for its intoxicating effects, but doctors still failed to take it seriously. A few American dentists, however, began experimenting with nitrous oxide. In 1845, a young dentist named Horace Wells decided to give a public demonstration at Harvard Medical School, showing how the gas could prevent pain. But he miscalculated the dosage. The substance didn't work fully. The patient cried out in agony, and the experiment was deemed a failure. For years afterward, Wells struggled to promote his discovery, but without success. Disheartened, he developed a severe mental disorder, became addicted to ether and chloroform, and was eventually imprisoned after, under the influence of chloroform, he threw sulfuric acid on 2 women's clothes. In his cell, he ended his own life by severing his femoral artery with a razor. Justice came only after his death. Today, his monument in a New York cemetery bears the inscription, Horace Wells, the discoverer of anesthesia. By the mid-19th century, ether had emerged as another powerful anesthetic. In fact, the first physician in the world to successfully use ether for surgical anesthesia was the American surgeon Crawford Long, who began doing so in 1842. However, because of his heavy workload, Long didn't publish his findings until 1849. By then, the credit had already gone to Boston dentist William Morton. On October 16, 1846, at Massachusetts General Hospital, Morton publicly removed a tumor from beneath the jaw of a young patient, Glenn Abbott, using ether. To everyone's amazement, the boy felt no pain. The audience was stunned, and by the next morning, Morton had become a celebrity. Just weeks later, Robert Liston, the very surgeon whose patient once fled the operating table, used ether during a leg amputation on a man who had been run over by a cart. Meanwhile, in 1847, Edinburgh obstetrician James Simpson introduced a new anesthetic, chloroform. It worked as effectively as ether, but lacked the unpleasant odor, was easier to inhale, and caused less throat irritation. Still, chloroform was far from harmless. In 1848, Simpson became the first doctor to document a death caused by anesthesia, his patient, a young girl named Hannah Greener. At first, British doctors were skeptical and used chloroform only rarely. But in 1853, Simpson recommended it to his most famous patient, Queen Victoria. She inhaled chloroform during the birth of her 8th child, Prince Leopold, and expressed great satisfaction with the relief it provided. And if chloroform was good enough for Her Majesty, it was good enough for her subjects. From then on, chloroform was used in Britain even for minor surgical procedures. By the mid-19th century, anesthetics still carried serious risks. Doctors had to calculate doses with extreme precision. Just a slight overdose could paralyze the respiratory center and kill a patient. Matters were further complicated by the fact that ether and chloroform were administered with special inhalers that made dosage control very difficult. Ether was also highly flammable, which forced surgeons to work with extreme caution. Fortunately, in 1853, doctors Alexander Wood and Charles Provaz, independently of one another, developed the hollow hypodermic needle. Even earlier, in 1845, Irishman Francis Rind had invented the syringe. These two innovations complemented each other perfectly, and soon anesthetics began to be administered more safely through injections. In 1884, Viennese ophthalmologist Karl Kohler, following a suggestion from his friend Sigmund Freud, introduced a new local anesthetic, cocaine. It was the first recorded case of nerve block or regional anesthesia. At first, the solution was applied directly to the surgical site and later injected under the skin. But it soon became clear that cocaine was far from safe. On November 18, 1884, in St. Petersburg, Dr. Sergei Kolomnin administered cocaine rectally to a young woman undergoing surgery on the rectum. Within 3 hours, she was dead, the first known case of a fatal cocaine overdose. Tormented by guilt, Kolomnin took his own life a few days later. In 1885, Dr. James Leonard Corning introduced spinal anesthesia to the wider medical community. And in 1901, epidural anesthesia followed. By 1905, a safer alternative, Novocaine, had been developed. By the early 20th century, the dangers of cocaine in medicine clearly outweighed its benefits, and Novocaine gradually replaced it. Yet, as late as the 1920s, cocaine was still sold in pharmacies as nose drops for congestion. Despite these advances, anesthesiology was slow to gain recognition as a field of medicine in its own right. Progress came gradually. In 1889, at the Philadelphia Dental College, Dr. Henry Dorr became the world's first professor of anesthesia. 2 years later, in Pittsburgh, the first medical journal devoted to anesthesia and narcosis, the Dental and Surgical Microcosm, was published. In 1905, the Long Island Society of Anesthetists was founded, the first professional association of its kind. By 1911, it had 23 members, and by 1936, when it had become the American Society of Anesthesiologists, it counted 487. In 1914, the first major textbook on anesthesiology was published in the United States, written by Dr. James Gwathmey. Meanwhile, scientists continued developing new anesthetic methods. In 1923, Dr. Isabella Erb was the first to use ethylene oxygen anesthesia in practice. By the late 1930s, thiopental had entered use, greatly easing patient suffering. In 1942, neuromuscular blockers were first introduced into anesthetic practice. In 1944, Swedish physician Torsten Gård pioneered the use of lidocaine. And in 1956, Britain developed halothane. By then, ether and chloroform had been phased out of medical practice worldwide. In the second half of the 20th century, anesthesiologists gained increasing insight into patients' condition under anesthesia, allowing them to make the process safer. By the century's end, advances in microelectronics and computer technology made anesthesia even more reliable. Today, anesthetics are carefully tailored to each individual patient. Modern anesthesia has become one of the safest procedures in all of medicine. Out of every 300,000 people who undergo anesthesia during surgery, on average, only one will die as a result of its effects.